So I thought it'd be worth just running through who's joining us today. So in terms of speakers today, we've got Dr. Jolie Keemink, who's a postdoctoral research associate in social care with the Applied Research Collaboration of Kent, Surrey and Sussex. So they're some of our colleagues within the AHSN. And she'll be talking to us about why LGBTQ issues are so important in residential care settings. And then we have Dr. Carl Marincowitz, who's a clinical lecturer in emergency medicine, working with our colleagues in Yorkshire and Humber. He's reviewed the research evidence about transfers to hospital from care homes, and he'll be highlighting some of the issues he's found later. And then we come on to you, so the people who are joining us. So we have our usual exercise that we like to do at the beginning of these meetings. So using either the thumbs up or the hands up or whatever emoji you choose to use, let's see if there's anybody here who works for a council, so a local authority, social services or another department. Do we have anybody from council? So we've got a few, you can see at least 3 or 4 people there. That's good. Okay, maybe we might get 1 or 2 more as the meeting goes on. So if those people could kindly put their hands down. Next, again, using either hands up, thumbs up, or however else you want to do it. Who's here who works for a care home? So care home managers, carers, nurses, other staff. Okay, again, we've got a few. Great. That's good. We've got lots of people from care homes. Excellent. And anybody who works for the NHS, either as a service provider or a commissioner or any other part of the NHS? Oh, right. I'm seeing more thumbs up than I saw for anybody else. Right, so council people and care home people, you're going to have to shout loudly if you don't want to get drowned out by the NHS today. And if there's anybody I've missed, any sector I've missed, maybe you could either put it in the chat or just let us know. Okay. And then, so finally, we have our PSC team members. So for people who don't know me, my name's Sean Farran. I'm a programme manager with the Patient Safety Collaborative for Kent, Surrey and Sussex. And as I said, we're part of the Academic Health Science Network. I can see Kerry's just put her camera on. Do you want to introduce yourself, Kerry?
Good afternoon, everybody. I'm Kerry Dudley. I'm sorry, the light's streaming through my window, so I'm a bit in silhouette. I'll change that in a minute. I'm working with Sean as a programme manager as well in Kent, Surrey and Sussex.
Ursula?
Hi, I'm Ursula Clark. I'm the Patient Safety Lead for Kent, Surrey and Sussex, and I work with Sean and with Kerry and with Bav and with Karen.
Okay, and as if by magic, Karen. Oh, you're on mute, Karen.
Things to think of here, yeah. Sorry, I'm Karen. I'm part of the patient safety team, being the business support side. Thanks.
Thank you. And last but not least, Bav.
Hiya, I'm Bav. I am the patient safety programme coordinator.
Okay. Thank you very much. So when we're talking to people behind the scenes, that'll be Bav and Karen that are moving slides and magically making things appear. So if I could have the next slide, please, Karen. So we're going to start off by just updating on the 2 programmes that were running in care homes last year by our team. And these are kind of year-end reports, and we'll just have a little look forward as to what we're doing in the year ahead as well. So next slide, please. So apologies to people who were at the last meeting, because they will have seen some of this slide. I did a summary then as well. But essentially, the aim of the medicine safety programme was about reducing medication errors in care homes. And you may remember we were testing 5 particular interventions. They were safety huddles, learning from incidents, managing interruptions, 3-way communication, and the use of safety champions. And the idea was that myself and my 14 colleagues from around the country were working with a number of different care homes to test these interventions out. We were gathering data that was then collected and analysed by the national team in order to produce a national report. Next slide, please. So locally in Surrey and Sussex, we actually started work with 8 homes, and we had quite a good spread there across the counties, as you can see. We also had interest expressed by a further 10 homes, so that was 18 in all. We were quite pleased with that. Unfortunately, those 10 came quite late last year, and there just wasn't enough time to enrol them on the programme and get started, given that it was due to finish at the end of March. But we did get as far as collecting baseline data with 5 homes, and 2 of those got as far as testing change ideas. There was another one that would have completed if we'd have had another month or 2, but unfortunately time caught up with us. Both those homes that did go through the whole process, though, were able to measure improvements in the areas they were looking at. The next slide. There was a number of reasons homes withdrew, and this won't be a surprise to anybody. Obviously, for a lot of last year, we were experiencing COVID outbreaks, and for a lot of that period, when a home had an outbreak, it virtually closed down, and it was all hands on deck. And associated with those outbreaks, there was a lot of staff sickness, either with COVID itself or people in self-isolation. Staff turnover was quite high. It continues to be high. We know this is a significant problem. For this programme, I think particularly amongst managers, we found there are a couple of homes that if a manager left or a new manager started, it really meant that it was very, very difficult to keep the programme going. And then just overall, we know the sector's been very, very busy and under so much pressure. It's been really hard to for people to lift their head above the parapet. So several homes had to withdraw, but we did manage to get some across the line. Next slide, please. The national report hasn't yet been published, but we do have some early findings, and the data was collected from about 40 homes around the country. The majority of those focused on managing interruptions, and I think that was our experience as well, that managing interruptions during medicine rounds resonated with a lot of people in care homes, and it was something that they wanted to address. And all the areas, to some extent, experienced similar challenges, so there were some themes that did emerge. Next slide, please. In terms of managing interruptions, teamwork and good communication was one of the issues that cropped up, as it does for a lot of these things, but also recognition that the medicine round is a safety critical activity. And what this means is if you're engaged in a safety critical activity, that should be coming first. So people were often in a dilemma that if they were being interrupted either by a visitor or a resident, they felt it was their duty to deal with that interruption rather than the drugs round. But actually, if you consider the medication round as a safety critical activity, that takes priority and you have to make other arrangements for the interruption. The importance of the 7 R's became paramount, and I've said 7 R's or 6. I've actually seen a model with 8 as well. So people who are involved in medicines hopefully will recognise that. That's about having the right resident with the right medication at the right dose at the right time, etc. I'm not sure if I got all 7 there. Nationally, the team decided that more testing was needed for some specific interventions. So phone diversion, we found in a lot of places, the person who was doing the medication round was also carrying the care home's main phone around with them, which is kind of essentially inviting an interruption. Also offering an alternative contact point for visitors, and the respectful challenge, as I say, being able to say to somebody, I'm sorry, I can't be disturbed at the moment because this is an important activity. And also people hopefully will be familiar with the red tabard. So that's about whoever's conducting the medication round actually wearing a red tabard as an indication that they shouldn't be disturbed. And that's had really mixed views up and down the country. It's quite divisive. A lot of people, I think, find that it causes more problems than it solves, certainly in care home settings. And it's not something that gained widespread support. Next slide, please. So the medication safety programme for this year actually has shifted focus, and it's no longer working with care homes, so we won't be talking about it at future meetings of this network. The national team felt that really that type of work didn't lend itself to a national rollout, which a lot of these safety improvement programmes are, that they need local focus, quite intensive support, as we found, and really was so subject to external pressures that it needed to be managed within local health economies. The medicines programme this year is going to focus on managing chronic pain by reducing opioid prescribing, and colleagues are already in discussion with pharmacists around Kent, Surrey and Sussex to try and kick that work off. And our care home work this year will be all about managing deterioration, and in particular about supporting the rollout of Restore 2 as a deterioration tool or equivalent tools. And on that note, I think it's timely to hand over to Kerry to give an update on what we did with that workstream last year. Hi, Kerry.
Hi, Sean. Thank you. Yes, I'm just going to have a little look back through the next few slides on the work that we did last year, which we really reinvigorated around April 2021, and then next steps, because unlike the programme Sean's just talked about, where we're not necessarily taking it forward within the Patient Safety Collaborative and the national programme, managing deterioration is very much staying and looking to scale up and involve more people as much as and as many care home settings as we can. Next slide, please. So the work we were doing, as I said, April 2021 to March 2022 last year, the aim was really to increase adoption and spread of deterioration management tools, and we're specifically talking about physical deterioration, so tools like Muse 2, Restore 2, Restore 2 Mini and SBARD, and also treatment escalation plans. And in Kent, they're very much moving towards adopting Respect as their tool of choice for treatment escalation plans and end-of-life care plans, and Restore 2 as their managing deterioration tool. So in 2021, it was really about raising awareness across the system and introducing tools for managing deterioration. So we did lots of virtual training. We were doing 2 sessions a week at one point, reaching out to care homes across Kent, Surrey and Sussex to do specifically around Restore 2 training. We've also done a lot more work the early part of this year around Restore 2 Mini, working with our leads specifically in Surrey and Sussex, looking at how we can have a train the model and get that message about Restore 2 Mini out. I think early on we made some assumptions that most learning disability settings might always want to use Restore 2 Mini, and I think as we've gone through the year we've changed that to thinking actually they may want to use full Restore 2 where they can, so we've adjusted our thinking a little bit on that. So I said we started with weekly training. As our numbers dipped off, we went to monthly training for care home settings and other colleagues. So as well as colleagues from care home settings, and by that I mean care homes, nursing homes, learning disability settings, we've also had colleagues from primary care networks and primary care, community nursing and commissioning come on to get an understanding of what the Restore 2 is. We've done some train the sessions, more on an ad hoc basis. So when a primary care network, for example, comes to us and wants to roll out across their patch, we'll look at working with paramedics or their lead nurses or pharmacists about how they might roll out to the care homes that they work with consistently. Taking it to primary care, we've talked to education network functions, we've talked to PLTs, protected learning time, and also going to practice meetings just to understand how they work with their care home settings around managing deterioration. We've also worked significantly with digital innovators across the patch, and specifically in Kent Dockbow. We have over 300 care home beds being monitored digitally, and the programme's going quite well. Slight pause at the moment, but looking to reinvigorate that in the next few months. We've also linked in closely with the CCGs and local authorities. So as well as reaching out to care home settings through our training and conversations, we're working with CCGs and local authorities to look at how their awareness of Restore 2 is and how they're rolling out across their patches. Next slide, please. So what did we achieve through that work? By the end of 21-22, so March 22, we had supported the adoption of deterioration management tools across 470 care homes across Kent, Surrey and Sussex. So about 28% of all care homes have adopted Restore 2. We started working with community teams, primary care networks and coordinators to help support care homes start using Restore 2, including baselining more complex residents. So we really started that conversation between primary care and care homes where we were working specifically in those areas. As I said earlier, we have 300 care home beds in Kent and Medway using a digital monitoring tool. And we can really see how that significantly saved time from both sides. So we hear that there's a lot less telephone conversations that need to happen because the referrals are made digitally, and that their GPs are able to respond with a much clearer picture of the resident that they're aiming to support. They have a full SBARD, which is the reporting tool, the escalation tool used in Restore 2. So we heard specifically as well how quite often residents were able to be reported by lunchtime and have their medication in place by the evening, and this particularly was useful on a Friday afternoon when the practices were closing. We've really got strong relationships coming along with our clinical commissioning groups that are moving into the ICSs and our local authorities. So we've been able to open conversations with them around this work. We've got plans for a digital care learning platform. It will be hosted in Kent at the Digital Innovation Centre, but available to all people across Kent, Surrey and Sussex working in the care sector or interested in these kind of tools. It will host Restore 2, as well as Respect, Esther and quality improvement activities. Next slide, please. So what's next? So as I said, this commission, this work is really ramping up this year. So we're hoping to reach much more than the 28% of care homes settings that we've already worked with across Kent, Surrey and Sussex around adoption. So we're continuing to support that and work towards our ambition of increasing that by at least 25%. We aim to use innovation to make the learning much more relevant and accessible, and I've alluded to the digital platform, which means people can access training that's staged and certificated within a time that suits them. We're also looking at simulation sessions, and we're trialling the first one of those in Kent on the 22nd of June with 2 care homes. So we'll work on 2 scenarios around a physically deteriorating patient, and again we'll share that with you when it's completed, and it will also form some of the modules on our digital platform. We really want to explore outcomes, the effect of the work that we're doing and the uptake of Restore 2. So to really look at each place, each area to see if we've managed to reduce hospital conveyancings, for example, or where we're working with primary care, has it reduced that telephone tennis, as some care home managers have called it, between primary care and care home settings. So really sort of looking at the impact of the work that we've completed. We want to work with a small number of care homes within primary care networks to support change, data collection and share learning. So again, very much building on the network that we've got today across the system, and continue to work with integrated care systems to explore the digital solutions that have been so successfully utilised and having real impact in Kent. So that's really a brief overview of where we were last year and where we hope to go this year, but happy to take any questions on that. Karen, Esther, it originates from a programme that was developed in Sweden or Switzerland, I can't remember, but it follows the journey of a resident and all the different people that were coming to see her and all the different places that she had to go for her treatment and all the time she had to talk about her wishes. So Esther is wraps in very, very closely with treatment escalation plans and end-of-life care, and it follows a resident's journey and really builds into those conversations and making sure the person's involved in their treatment and care. And you start off by being an Esther ambassador and you go through to being an Esther champion, and it really is very helpful for care home settings. At the end of this session, there's some training being released around Esther. You can actually do it online at the moment, but there is going to be some face-to-face sessions. So we'll share how you can access that, Karen. I'm just trying to look and see if there's any other questions in there. We've got one from Pam saying Wizan is a very useful tool in care homes and does help avoid unnecessarily hospital admissions. Yes, I believe that's very much a similar setup. I'm less close to the detail in Wizan than I am with Docabo, but I think it's a very similar setup. Is there any other questions?
Just to say, Kerry, Jolie has put a useful link in the chat to learn more about the Esther model. And also, I think we've got details of a workshop at the end of this network, haven't we, that people can join if they want to know more.
Jolie, if you wanted to add anything to my comments on Esther, you're probably much more expert than I am.
I'm not really. I just I know that Kent before the pandemic was quite keen on using the Esther model, and it all got a bit snowed under in the pandemic. But I think it's a very interesting model and worth looking at.
Thank you. Yeah, I totally agree, and I'm actually down to have my training soon, so I will be more well versed in it. But so it's not actually limited to people practicing as well. It's about raising the awareness across the system. So don't feel you can only go if you're actually working in a care home setting. It is meant to be. It follows Esther's journey through her care, so it's relevant. I think Esther's everybody's business. I'm just going to check. I haven't got another slide to talk to. I don't think so. Next slide, please. No. So is there any other questions that anybody wants to ask Sean or I about the national programme at all, or our work streams in particular? No. Thank you very much for listening.
Thanks, Kerry. And that was a timely introduction, Jolie. So I'll just hand over to you now, if that's okay.
Thank you very much, and thanks so much for having me today. So yeah, I'm Jolie Keemink. I'm based at the University of Kent, but I work for an organisation called the Applied Research Collaboration that is very closely linked to the AHSN, actually. And today I'll be telling you a little bit of my work around LGBTQ+ inclusion in residential care for older people. Next slide, please. What I first wanted to do is unpack that term a little bit, because it may mean more to some than to others. There's also some, I guess, different opinions around whether we should use it, what should be included. But for now, the most commonly used term is LGBTQ+, which stands for lesbian, gay, bisexual, trans, and queer. I don't think I have the time to fully go into what all those terms mean, but I think what is important to cover is that LGBTQ+, that sort of acronym covers sexual orientation, but also gender identity. So it's about two separate things, sexuality and gender identity. And people can also feel like they identify with multiple letters from this acronym. So you can be trans and bisexual, for example. I think it's really important to note that it's very personal preference, what sort of term people identify with, and that you should never assume that people identify as a certain label, and some people don't like any labels at all, and also that it's something that can change over time. And that's obviously perfectly allowed. So the way people identify can change over time. I think that's an important point to make. And something else I wanted to add is that pronouns is also an important part of this. So that specifically relates to gender identity, and something that you may have seen a lot more in, for example, people's email signatures, that people have started to include their pronouns, which is, I think, is a great development. Next slide, please. So yeah, I just wanted to start with that term LGBTQ+, because I'm going to use that throughout my presentation. So I hope that's a bit clearer now, but feel free to shoot me any questions if it's not clear. So I've been doing some work around the inclusion of the LGBTQ plus community within residential care, and then specifically focusing on older people. And I just wanted to start by looking at what is already known from the literature. So what has already been published, what has already been looked at. So it is known that LGBTQ plus people in general face poor health outcomes and fear. They also experience fear of discrimination, or they experience discrimination, and this causes reluctance to access health and care services, which is obviously problematic. In addition, older LGBTQ plus individuals are affected by, I've written lazing there, which should be lasting, a lasting legacy of discrimination, stigma, and criminalization. So a lot of people have vivid memories of, for example, the HIV pandemic, but also Section 28, the decriminalization of homosexuality, which are all very important contextual factors to how much trust and confidence people have in the systems around them. And I think it's important to take that context into account when talking about this subject. And then looking at providers, although they are willing, they are often not sufficiently equipped with the skills and knowledge to be LGBTQ plus inclusive. Next slide, please. So I did, together with some colleagues, I started with doing some consultation in Surrey and Sussex, looking at experiences of older LGBTQ plus people in KSS related to residential care, but also talking to care providers and commissioners. And I'm first going to talk about what we found about the experiences of older LGBTQ plus people. So these were people who either were close to going into residential care or had had some experience of some respite care, for example. Yeah, next, I want to say next slide, but it's, yeah, they come up in a little bit. So the first thing is that people are concerned about discrimination from staff and other residents, which they've often already experienced in other settings. Next bit, please. They are worried about the interaction of dementia and sexuality or gender identity. So there's not very much known about what happens when you have dementia and, for example, you've always lived, say, as a trans woman. Could that, the way you present or the way you talk about that, could that change when you have dementia? And people are worried about that. Next one, please. They are worried that the significant people in their life won't be treated equally to heterosexual partners or marital partners. A lot of people from the LGBTQ plus community speak about their chosen family, which is not always the same sort of relationships that are seen as conventional, but they would mean the same thing to people. And for example, I've heard stories about people that were in a relationship, but they weren't married, for example, or they were a same-sex couple, and then they weren't as involved in the care planning of that person because their relationship was seen as differently. Next one, please. They're concerned about that there will be no place for their individuality, whereas at home they can maybe explore certain parts of their individuality related to their sexuality and gender orientation. They're worried that that is not the case within residential care. Next one, please. They're worried that they will have to go back into the closet to be safe. Next one. And they're worried that through all of that, they will become isolated. So then the next slide, we'll talk about barriers to more inclusive practice. So what is currently in the way to establish more inclusive care provision? Next. Please, thank you. So first of all, the staff, the care provision staff and managers of care homes and commissioners that we've spoken to said that they don't feel very confident talking to people who maybe differ from the heterosexual or cisgendered norm. Next one, please. Care provision is also rooted in heteronormative and cisgendered values. They're very big words. What I mean is that it's mostly set in a framework of heterosexuality. So often it's assumed if you are an older woman that you will have a husband or will have had a husband, that you will have children, for example. And cisgender refers to the fact that you identify with the sex you were assigned at birth. Next one, please. There's also a lack of understanding that gender identity and sexual orientation are relevant for someone's care needs. So we've often heard that people say, well, I don't really look at that. I just treat everyone the same, which is obviously comes from a very good place, but it sort of neglects the fact that it's actually really important to someone that their gender identity and sexual orientation are seen and how it relates to their care needs. Next one, please. That there's a general lack of training on equality, diversity, and inclusivity. And that's not necessarily because people aren't willing, but often because there isn't the time, there isn't the money, there aren't the resources. So that's something to take into account as well. Next one, please. Then there's often the belief that there are no LGBTQ plus residents. And it's not like all of us disappear when we are over 60. It's often the case because of the concerns I just mentioned in my previous slide, that people aren't visible, and you get into this sort of vicious cycle that people aren't visible, and then their barriers aren't in place, so then they still aren't visible, and then we keep this belief that there are no older LGBTQ plus residents in care. Next one, please. And finally, there's also an absence of clear and specific regulations related to LGBTQ plus inclusive care. So looking, for example, at CQC reporting of what good care consists of, they mention something about sexuality, but it's very, very minor. Within commissioning, there's often also not a huge amount of focus on it. So there are interesting barriers to explore. Then I want to quickly, because I'm looking at the time, I just want to quickly discuss the next slide. There's, based on what we found in those consultation exercises, there's a need for resources that, next one please, improve the experiences of older LGBTQ plus residents. Next one. Improve staff knowledge on how to be more inclusive and why it matters to people's care needs. They are feasible to implement in the current care climate, so we want to take into account the pressures that people are currently under. They are informed by the needs and experiences of the LGBTQ plus community, so they're actively involved in shaping these resources. They're long-lasting and sustainable. They're easily updated because needs and context can always change. The resources support holding providers accountable to be more inclusive, and also they enable truly personalized care. Thank you. Next slide, please. So there definitely already are some resources available, and some of you may be aware of these. They're mostly theoretical guidelines. For example, HUK, Stonewall, and Skills for Care all have great theoretical guidelines available. The problem is there isn't very much known about how these guidelines translate to practice, how are they implemented, and how are providers or commissioners supported to use that guidance in practice. There's also one academic case study that looked at this initiative within residential care to make a set of homes, I think it was in the Midlands, more LGBTQ plus inclusive. It's quite time and resource intensive, and there are also training programs, for example, by the biggest UK charity for older LGBTQ plus people, Opening Doors, and Switchboard, a charity in Brighton that I collaborate with. But these training programs are often quite expensive, and there's not always the time and the resources to invest in those. So there are some resources, but not everything is freely available, or it's not very clear how they should be used in practice. I see someone's coming on camera. Do you want to ask a question or no? Okay. Next slide, please. I'll just tell you a little bit about the projects I'm currently involved in. So that was sort of like background work I did to set up several research projects. One smaller project I've started with is looking at the role of commissioners to promote and safeguard LGBTQ plus inclusion in care. So I've been working quite closely with commissioners in Brighton and Hove, but also in West Sussex and East Sussex. That really indicated that there was this great willingness to be more inclusive in their commissioning process, but they didn't really know how, they didn't really have the tools. And we're currently undertaking interviews in the survey to explore what their role is and how we would envision the role of commissioners in a sort of ideal scenario, and what we will, based on that, develop some recommendations for commissioners. Next slide, please. And there's also a larger project in setup that I've actually just heard yesterday that I was selected to proceed to the stage 2 of the funding application, which is great news. Where I'm working with a large amount of partners to co-produce a resource that enables care providers to be more LGBTQ plus inclusive. And it's really important that this resource is something that's freely available and that's very feasible to implement. That will be co-produced, which means that you produce it together with all the different stakeholders involved, who are mentioned on the next slide. Next slide, please. Yeah, and can you just click a few times? I have added this really nice feature of doing all the clicks, but it's not that handy when you're not controlling the slides yourself. Thank you. Yeah, 2 more. Thank you. So it's really important to me to include all these groups and bring everyone together to make sure that we develop something that's truly informed by everyone's needs and works for everyone. And these are the stakeholders that we currently in touch with. So that's care home managers, care workers, informal carers, older LGBTQ plus individuals, local authority commissioners, regulatory bodies like the CQC, integrated system leads, and important partners from the voluntary sector. But I'm very open to suggestions if there's other stakeholders that you feel would be important as well. So yeah, next slide, please. I think I'm gonna leave it there. That was a bit of a whirlwind, but I'm very happy to hear your thoughts or questions. I'm still very much in the middle of these projects, and I'm very happy to hear from anyone if they would like to be involved or if they have questions or suggestions. Thank you very much.
Thanks, Jolie. I think it's possibly, I mean, I find that very interesting, but it's probably worth pointing out that this really boils down to individualised care, doesn't it? And there's no specific right answer all the time. So
absolutely.
Even some of the language and the ideologies you've talked about today would not be universally accepted across the community.
Absolutely, and I think I tried to emphasize that when I talked about the acronym, that I think it's really important that it's what we talk about is truly personalized care, and you can't say that everyone wants the same just because they are part of the LGBTQ plus community. No, thank you, Sean.
Karen asked whether we have any examples of good practice care provision. I'm guessing from what you're saying that this is such early days that there isn't a specific example that you could point to.
No, well, I think there are some anecdotal stories that I've heard just through my engagement work. And I think it's maybe important to realize that it can start really small. It may feel like a really big mountain to climb, but it can already help very much for people if, for example, in imagery used on posters or websites, they see a same-sex couple, or if a provider is very active in organizing something for Pride Month, or if there are certain symbols that people wear on like their lanyards. So we at the university have rainbow lanyards to make sure that people are welcome and safe. So yeah, there are small things I think you can start with that already signal good practice.
Thanks. So Kerry, I think you put your hand up first.
Just a quick question, really. as much as an observation. I think we're exploring some of this in our mental health programme as well, around equality and diversity, specifically with reducing restrictive practice. And when we're looking at admission documentation and incident documentation, we are starting to ask ourselves how comfortable staff are having these conversations, and that's in big NHS trusts. So I wonder how we empower our care home settings colleagues to feel confident to have these kind of conversations with their residents, or whether that's a learning disability service as well, equally important. We may overlook that too.
Absolutely. I think confidence is a very big part of it, and looking at when we start to co-produce this resource, whatever it may look like, because I don't want to prescribe that. I really want to co-develop that with all the stakeholders mentioned. I think looking at how we can help support people feel more confident in that is a really important aspect of it.
Thank you. Debbie, did you have a question?
Yes, I did. I suppose, I totally agree there needs to be more conversations, and we need to reform within the care service. But is there a risk by focusing on LGBTQ plus, you are then almost creating a division, saying there are people who are not LGBTQ plus, and therefore you're almost creating a division, and that should it be more a focus on sexuality as a whole and person-centered care, if you see what I mean. I just think it's quite a difficult one, that as you try and focus on it, and I wholeheartedly agree that it needs to be addressed, but by focusing on a particular under that acronym, you're almost by definition creating two separate divisions of people, those who are inclusive in that and people who are not. And I just think in care that there's a danger, as I say, we don't have the resources and the training. There's almost a danger of us focusing too much and therefore dividing people, which is not what we want to do. So I just think we all need to be quite careful. People are trying to be very responsive and include it in all their policies and everything. But I just think that there is a danger that we could be creating an imbalance or something. But I think we should treat people individually.
No, thank you very much for that point. I think that's a very good point. And I think, again, it's going to come down to personal preference, whether people like to be approached as different or not. But I think maybe we should approach it more from the idea of celebrating difference, and that difference, whatever that may look like, is something to be celebrated. And maybe it shouldn't even be just excluded as looking at sexuality, but you obviously also have the intersection of things like sexuality, ethnicity, learning disability, religious background, and ideally it would be seen in a larger framework of that, where all these individuals who have things from those different sort of knots in the network. But I think that's a very good point, and thank you for raising it.
Okay, well, thank you very much, Jolie, for coming today and giving your presentation. I think it's one of those subjects that we don't talk about enough, and it's really helpful to put it on the agenda and just help us to start thinking about it. And it's certainly not our intention to find answers to every problem here today, but the very fact that you've helped us to start thinking about that is helpful in itself. So thank you very much, and you're getting a few rounds of applause there from.
Thank you very much for having me. And yeah, my email address is on this slide, but I'll put it in the chat as well. I'm very happy to be contacted. Okay. Thank you for having me.
Thanks, Jolie. So now we're going to have a 10-minute comfort break. So to kick off our second part today, I'm going to introduce Dr. Carl Marincowitz, who's a lecturer in emergency medicine up in Yorkshire, University of Sheffield, I think. Over to you, Carl.
Hello, and thank you for the opportunity to speak today. My name is Carl Marincowitz. I'm an NOHR clinical lecturer in emergency medicine. This means I'm an A&E registrar 50% of the time, and do research at the University of Sheffield the other 50%. I'm conducting a project assessing reasons for variation in hospital transfers of care home residents as part of the Yorkshire and Humber Arc. Next slide, please. The UK population is rapidly ageing, with over 20% of the population projected to be aged over 65 by 2030. Although only a small proportion of people aged over 65 are care home residents, they account for a disproportionate number of ED attendances and inpatient admissions. Around half of the care home population have a significant degree of frailty, and 2/3 have some degree of cognitive impairment. The average life expectancy of care home residents in the UK is 24 months in care homes without nursing and 12 months for care homes with nursing care. Next slide, please. So why do we want to reduce hospitalisations of care home residents? Well, firstly, there are established associated risks, including hospital-acquired infection and reduced function. Transfers can also be distressing and increase the risk of worsening confusion on the background of existing cognitive impairment. Work by the Health Foundation found that up to 40% of hospitalisations could be avoided and were for conditions that may have been treatable in the community. However, once hospitalised, care home residents are more likely to undergo investigations than other older adults. Such emergency inpatient treatment is costly compared to other models of care. Although the majority, 7 to 80% of deaths of residents occur in care homes, 40% of residents have at least one inpatient admission in the last month of their lives. Next slide, please. Existing research has found up to 8-fold variation in rates of hospitalisations between different care homes. Some commentators have proposed the use of continuous monitoring of rates of emergency admission or place of death of care home residents as potential care home quality indicators. Next slide, please. As the first part of the work I'm conducting with the Yorkshire and Humber Arc, we completed 2 systematic reviews. The first ended up as a synthesis of existing research and qualitative reviews exploring the experience of residents, family and care home staff of decisions to transfer residents to the ED and factors which influence these decisions. The second was a more straightforward systematic review identifying factors which were associated with likelihood of resident transfer to the emergency department. Next slide, please. I'm not going to go into a lot of detail about our review methods here, but we conducted the reviews in accordance with NTREX and PRISMA guidelines. We searched multiple electronic databases and grey literature. The qualitative component included 6 previous reviews and 2 accompanying full reports. The quantitative component included 23 primary studies. Next slide, please. We identified 3 common important themes in our review, exploring experiences of transfer decisions. The first was that transfer decisions involve multiple stakeholders, including residents, family members, care home and clinical staff, and there is a hierarchy within these decision makers. Family members' wishes were often prioritised. Residents could feel excluded from decisions. Care home staff felt they needed to negotiate or control information in order to achieve the outcome they thought was needed. Despite their important role in the hierarchy, family members could feel uncomfortable making decisions, especially regarding end-of-life care, leading to uncertainty and hospitalisations as the default. Next slide, please. Some hospitalisations are made reassuringly with a positive intent of improving outcomes for residents. These are characterised as being resident-dominant by Farran et al. Some conditions, e.g. broken bones, were always thought to need admission to hospital. Next slide, please. However, some hospitalisations occur due to factors external to the resident with no expectation of improving resident outcomes. These were characterised as being resident subordinate by Farran et al. Such external factors could include perceptions of high staff workloads in the facility leading to unsafe care, or being unable to access community services to support treatment in the care home. A strong recurring theme was the fear of medico-legal consequences staff had in not transferring acutely unwell residents, especially when advanced care planning was not robust or where communication with family members was difficult. Next slide, please. This is a shortened summary of the results from our quantitative review. We found 7 common domains which were associated with likelihood of transfer to the emergency department. These were demographics, comorbidities, frailty, medication use, permanent indwelling devices such as urinary catheters, presence of advanced directives and care home factors. Importantly, there is no simple relationship between increasing age and frailty and likelihood of transfer, with both younger and the oldest most frail residents being less likely to be transferred. Specific conditions like heart failure and COPD, polypharmacy were all associated with increased likelihood of transfer, and may be potential targets for interventions. There was also a clear relationship between services available at care home and quality rating and likelihood of transfer. Next slide, please. Reducing avoidable hospitalisations has clear benefits for both the NHS and, importantly, residents themselves. However, transfer decisions are complex. They involve multiple stakeholders and occur within the context of individual care homes and the health system in which the care home exists. Decisions to transfer may be less dependent on the nature of the acute deterioration of the resident and more about communication between stakeholders, especially family members, and robustness of advanced planning. Our quantitative review has identified potentially modifiable risk factors to avoid admission and information regarding factors which may need to be adjusted for if continuous monitoring of hospitalisations for care homes is used as a quality indicator. In our future, next slide please. In our future related research, we're using routine data to estimate variation in rates of transfer between care homes in Yorkshire and the Humber. We're updating a systematic review of interventions to reduce hospitalisations from care homes. I'm also in the process of working up a grant proposal to model and better understand reasons for variation in hospitalisations between care homes and recommend tailored interventions to reduce hospitalisations from care homes with high rates of transfer. Thank you for listening, and I'll now take any questions.
Thanks very much, Carl. While we'll just wait to see if there are any questions from the floor. I think it's helpful to point out some of those themes, particularly around the medico-legal risks and fears of staff, can actually be helped a great deal if the people are using a proper either care planning tool or a tool like Restore 2 that actually makes some of that decision making much more objective. And of course, if anybody's interested in Restore 2, you just need to contact Kerry or I, and we're certainly supporting that across Kent, Surrey and Sussex. Kathy, you have a question?
Yeah, when you looked at your research and your data, with some of the care homes that now are residential, not nursing, because we've seen an increase of the large corporate homes building large residential homes because they can't recruit nursing staff, and then having a dementia floor. Did you see a higher rate of transfer from those homes or no difference?
Yeah, that's a really good question, Kathy. So I think in the literature, it's actually quite hard to differentiate between nursing homes and sort of just general care homes. And there's quite a lot of variation internationally. What we did find was that care homes or nursing homes which had specific dementia units had lower rates of transfer.
Right. Yeah. Okay, that's interesting. And the other thing that we've come across in Surrey, that in a meeting we were discussing around care homes this week, is a reluctance of some homes now to use either Restore or the Wisdom Box or the Muse, because it feels it's putting pressure on care home staff to make those clinical decisions, and actually we need to explain actually it's about supporting so they're not making clinical decisions. And I think there's that fear that actually they start using this, they're making a clinical decision when in fact they're not. So, and there's a reluctance now for some homes to use it.
Yeah, so that is a theme which came across, is that a lot, for what the qualitative component, a lot of the time care home staff feel that managing the resident in the care home is more appropriate and will be better for them. But if they don't have the support to make that decision, then they can end up hospitalising residents as kind of a default. Sorry, my cat's trying to get involved in the background.
Hi, so somebody else put their hand up. Was that Alison?
It was, I think I'm just, here we are.
Hi.
Thank you, very interesting. I'm currently amongst other things, in CSM for care home matrons as well, which is why I'm interested. But I've spent probably the past 20 years of my community nursing experience, mission avoidance, that type of thing at the other end rather than the front door. But what I've noticed is that seems to not change in the past 20 years is when a resident has entered the acute sector, the actual reluctance for the hospital, despite the charge of getting them out, is actually releasing residents back into the care homes and elongating their stay. I know this goes totally against what's currently going on in all our acute trusts as well, but the reality of it is that is there some kind of, we've tried money kind of seminars and information sharing to say what actually is out there in the community to support people, particularly care homes. But there still seems to be a bit of reluctance to actually let them go. I mean, so of course we're trying to present them going in, but actually if they do need to go there, is actually get them out again. Is there any kind of work or any kind of research or anything about that reason? I know it's a bit sort of nebulous what I'm just saying, but I have noticed that it's something that seems to be really widespread and actually quite embedded.
Sorry, it's my cat. Yeah. No, so this is exactly my experience as an A&E doctor, is that once, and also the research that has been done sort of bears this out, is that once residents are in the hospital kind of factory, they end up having a lot more investigations and treatment than other older residents. And I think part of the reason, and this is my experience as an A&E SHO, is that when you start from scratch with someone who can't advocate for themselves, the kind of default position is you do everything, you do more investigations. And then it's difficult to stop that process once that's started. Within the systematic review that we're doing to look at interventions to reduce hospitalizations of residents, there is a domain which is kind of ED and hospital interventions. And just anecdotally, from my experience working in a hospital, the kind of things which have been done is putting geriatricians at the front door and quite senior sort of consultants, because they're able to make kind of more sensible decisions. The other thing which came out in the qualitative aspect, which I think is equally important in hospital, is the kind of dynamic with family members. Because if someone's not able to advocate for themselves, then having the family on board with kind of decisions to not do everything is quite important, or at least, because we also have kind of medico legal fears, it also kind of helps with that kind of decision making. Does that help answer your question? Yeah.
From previous experience to that places that use the red bag, so part of the HCH is the red bag scheme, where people admitted from care homes come with their belongings in a particular red bag that includes all sorts of information, and where that works well, it prompts much better communication between the hospital staff and the care home staff. So actually it breaks down some of those barriers about expectations and understanding of what's available. Obviously it doesn't work well everywhere, which can be a problem.
Yeah, and I think one of the things that's really interesting in the kind of future grant is using routine data to look at where different things have been implemented in different ways, and using routine data to see what the effect is. Kind of the perverse thing is that in hospital, it's actually easier to do something than not do something. So as a junior doctor in A&E, it's easier to admit a resident than to contact the family, contact the care home, and try and discharge them.
Thanks, Carl. Kerry, you were going to ask a question?
Hi, yes, Carl. I was just wondering, in terms of the qualitative aspect of it, when you spoke to care homes about their, especially the ones that had high admittance, was there any sort of feeling after the research was done that they'd made changes or explored that, having read the results?
Sorry, I just missed part of that question. Could you just say that again?
Sorry, I'm thinking of the qualitative aspect where you spoke to care home staff specifically, especially those with high referrals or high hospital admissions. Was there any sense of them taking on board some of the sort of findings from the research, or has that not been explored yet?
Not been explored yet. And also what we did was a review of qualitative literature, so we weren't doing actual interviews. Sorry, that wasn't.
Okay, no, I probably missed that bit. Sorry. Thank you.
I was probably going a bit quick, or the cat was attacking me in the background.
Thanks. Debbie, did you want to come in?
Hello, yeah, I've just got two things. I think on your slide it said 40% of admissions were avoidable, and I just wondered, were there any sort of common themes like falls, UTI, or was it symptom-based shortness of breath, pain? That's one question. And the second one was there any data collected on what day of the week the admissions occurred. So, for example, sometimes in a care home, you notice and you've reacted to, or you've responded to the individual. But as you're coming up to your Friday, that's when people think actually there's no GP cover, so therefore they may be more inclined to call an ambulance, etc.
Okay, what I'll do is I'll share the link to the Health Foundation report. I'll dig it up and I'll share it in the chat in a minute. I can answer the first question directly. So what they did is they looked at routine data, and it was for specific conditions like UTI or chest infection with falls, which could potentially be treated in the community. So that's how they got that 40%. In terms of days of the week, I'm not sure off the top of my head if they looked at that. But as I say, I'll share the report in the chat and then you can have a look at it in more detail.
Thank you.
Yeah.
Okay, I think that's a good time to bring that discussion to a close. So thank you, Carl, very much for coming and presenting, and thank your assistant for joining in as well. You're welcome to stay for the rest of the meeting. It's certainly been very interesting, and again, we'll stimulate some helpful discussion. So thank you very much.
Thank you.
Thanks. So, thank you, Karen. So we're going to move on to a session now about quality improvement. And people who attend this forum regularly will recognise that we do try and sneak a bit of quality improvement into each meeting as we can. It's part of our remit to try and increase quality improvement capability across Kent, Surrey and Sussex. And Kerry and I have decided that this year we're going to be slightly less subtle about that and actually have a structured session at each network looking at some specifics around quality improvement methodology. So today we're going to cover some of the headlines, and apologies to anybody who came to the very first one of these meetings about a year ago, because some of the slides you'll recognise from that presentation, but hopefully they'll have a bit more context now. Next slide, please. So specifically today, we're going to look at what we mean by quality improvement. We're just going to touch on why culture is so important and why people always talk about safety culture when we talk about quality improvement. And we did have a session on safety culture a couple of meetings ago, so hopefully that will be revision for some people. And we'll talk about how to identify a quality issue. Next slide, please. And then in the next 3 meetings, we're going to cover topics around getting a better understanding of quality issues and developing change ideas further, then testing, measurement and implementation, and finally overcoming obstacles. So we have a plan for the year. Basically, we'll be covering each of these. Next slide, please. And we're going to start off with an exercise which hopefully will go smoothly because we're using forms which we've not used before in this context. And we're just going to ask people, so Bav, are you going to come in at this point? So we're going to ask people which quality management models on this link on, here it is, it's on screen now. So which of these quality management models have you heard of? And you should be able to tick however many you've heard of. So if you could just go through those and tick the ones you're aware of. There's no test associated with this, so you don't have to answer questions on them. Although there is a hidden question, which is how old are you? Because some of these go back a few years. You'll be pleased to know your answers are anonymous. Yes, Ursula, you're jumping to the next slide. Okay, so some of these are very well known. Total quality management is quite old now, but has been around for quite a while, and continuous quality improvement has been used in health service a fair bit. Some of these, of course, have got quite a bad reputation because they were trademarked and actually they became more of a source of income rather than quality management. as I say, ServQual, I think is quite an old one and didn't really take off very well in health and care. So we've got an idea there of what those different models, how well known they are. So the important thing about each of those models is that they represent a systematic and structured approach to quality management. And even though, as I say, some of them have got a relatively bad reputation, it's important, I think, when we talk about quality improvement, that we talk about it in a structured and systematic way. And it's more than just looking at a problem and thinking how you're going to address it. Next slide, please. So what we do now in healthcare, if you hear people talk about quality improvement or QI, we're generally now talking about the IHI, so the Institute of Health Improvement model for improvement, which is often represented like this. It's essentially 3 questions. So what are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in an improvement? Accompanied by that circle there, which people may recognise, Plan, Do, Study, Act, a PDSA cycle. So this is a common model, and it incorporates various elements of all those other models we were talking about earlier. The most important thing is it's been developed specifically for use in the health and care environment, and it's broad enough that it can be adopted for almost any type of sector. So next slide, please. The 3 stages are pretty straightforward. So the question what we're trying to accomplish is about setting aims for the exercise. How will we know if a change is an improvement? Is all about establishing measures. So measurement is really key when we're doing quality improvement. And what changes can we make that will result in improvement is about testing those changes. We test each one to identify if it's having an impact, whether we adopt it, adapt it, or abandon it. So next slide, please. So I'm just going to bring culture in here, and we could do a whole session on culture again, but I think it's useful just to put it in context here. So I think it's fair to say a lot of workplaces still exist in a blame culture. And a blame culture really means that if something goes wrong, there's an assumption that there's somebody to blame. It's somebody's fault. We can either blame ourselves or blame others. But it kind of implies that somebody's gone out of their way to make a mistake on purpose. And that kind of culture silences people, and it does not encourage people to come forward. It does not encourage people to be honest, and therefore it does not encourage people to look at problems in an honest way and find an honest solution. So next slide, please. You may not be able to see the detail on this. I've just put this up. This is the kind of basis of the healthcare safety investigations process, and it categorises different types of unsafe acts. And you'll see only the bottom intended violation is somebody specifically going to work to intentionally do something that's unsafe. And they are very, very rare. That's when you kind of get murderers and people like terrorists and people. The vast majority of errors are a result of either unintended action, which could be a slip. A slip is basically people lose focus. So we were talking about managing interruptions in medicine rounds before. That's a slip if somebody's attention is diverted elsewhere. Or a lapse, which is just people forget something, lose their place. Again, it can be because their attention's diverted, or just there's so much going on at the same time, which we're all familiar with in our jobs. Or it can be intended, but a mistake. And mistakes tend to be either because a rule has been misapplied, so a rule that's perfectly appropriate has been applied wrongly, or we have to accept that some of the rules just are not fit for purpose, and we mustn't be afraid to look at if we need to change rules. And then possibly one of the most common reasons for unsafe acts are about lack of knowledge. So none of these suggests that somebody went out of their way to intentionally make an error. Next slide, please. This is the Health and Safety Executive definition of safety culture, and it's a combination of attitudes, values, and perceptions. influencing how something is actually done rather than how it should be done. And they talk about attitudes, values and perceptions. On the background there, we can also see language, norms and behaviours, and they're all factors that contribute to a culture. People often say the culture of an organisation is the unspoken rules about how we do things here. So as I say, that includes the language that's used, the accepted norms, the behaviours that you see on display, but also the values and perceptions that you see in people. And this comparison of how something is actually done rather than how it should be done is part of a concept. Next slide, please. That's talked about by Stephen Shorrock. And again, this is a concept we could spend a whole session talking about, but he's essentially saying any work can be divided into 4 areas in this. There are gaps between each of these. So the work as prescribed is the kind of standard, the policy. Work as imagined is when somebody's thinking about how something should be done rather than actually doing it. And then the work as done is what somebody actually does compared to the work as disclosed, which is what they may tell people. Now, some of these gaps will often be very small. There might just be a very, very tiny difference between what you've actually done and what you told somebody you've done. Sometimes they're huge. And obviously, when we're talking about safety, one of our objectives is to try and minimise that gap as much as possible so that the work as done is as close to work as disclosed as it can be. And part of the environment you need to do that is a safe environment where people don't feel that they're going to be blamed for making a mistake, but they do feel safe that they can disclose what they've done so that a solution can be found. Next slide, please. So that leads us on to a kind of quality issue that you might choose to look at. And sometimes it might be obvious. So if you've had a CQC inspection with a long list of quality issues, it might be quite obvious which you need to tackle first, but it might not be as obvious as you think. It's really, really important to engage and listen to the people that are closest to the problem. So in a care home setting, that's likely to be carers, family, visitors, or the residents themselves. What matters most to those people, and it's important again to listen to them and engage with them about that and not to make assumptions, because we tend to make assumptions about what we think other people feel rather than engage and ask them the questions. And when you've been through that engagement and discussion, do you have any data that might be helpful? And we all have data in our jobs. It's how do we make use of it? So you may, for example, be able to look at your complaints, your incident reports, just resident feedback or anything like that might help you make a decision about whether an issue is worth pursuing. And possibly one of the most important things to think about is who will need to own the changes. So if you're going to do some quality improvement, there will be some actions arising from that, and somebody's going to have to undertake those actions. That's going to be much more straightforward if the people undertaking the actions actually feel they own them and they've come up with them, and it's to address a problem that they have identified. Next slide, please. So we offer some tips, and we are really kind of whizzing through this, only doing the headlines, but it's just about giving you an overview of what the process might be if you're choosing a quality issue to work on. So it works best if there's a problem that's not completely understood. Obviously, if you've got water pouring through your roof, you wouldn't set up a QI exercise to try and resolve it. You'd just have the roof fixed. And if there's a very obvious problem, the solution is just to get on and address that. But if you don't completely understand what the issue is and you think you've put things in place but they're not working, that might be an indication that QI would be a good way of addressing it. But before you can really improve it, you need to know how it really works. So that's the work as done compared to the work as prescribed or the work as disclosed that we talked about before. So you need to create that safe environment where people can feel they can disclose what they've done without fear of blame. And QI is about small changes. It's about baby steps. We're not talking about the kind of change process that changes whole care pathways or whole service configurations. These are very small changes that you can measure, you can change, you can test, you can measure again, and you can see whether they've made any difference. I think one of the key things to remember if you are doing some QI work is not to be put off by previous failures. There's a quote that's often used, I think, by Thomas Edison that says something like, I haven't failed, I've just found 1,000 ways that this is not going to work. And it's really important that if you feel something's failed, actually it's useful you've identified that that is the wrong way of doing it, and that could be helpful. Next slide, please. And this is my last slide, that to remember you're not out there on your own, you're not reinventing any wheels, you're not creating any new processes. There are lots of tools out there that can help you with this. I've just listed some of them there: 5 Whys, brainstorming, process mapping. So people have probably done some of those things. Those and lots of other tools are available via a lot of different websites. So I've listed some there. The Institute of Healthcare Improvement has a lot of resources on its website. There's a site called LifeQI that has lots of resources. And the Social Care Institute for Excellence has lots of really good stuff specifically targeted at social care. E-learning for health, if people aren't registered for e-learning for health, I would really recommend it. It's available for everybody working in health or social care. It's free. There's lots and lots of online training, some of it targeted specifically for social care. A lot of it is designed for healthcare, but it's relevant anyway. And there's some really good modules on there about patient safety. And if you can overcome objections to the word patient and the fact that all the examples are based in hospitals, it has a really good grounding in some of this quality improvement methodology. If that's a bit too health focused for you, Skills for Care also has some useful modules on the basics of quality improvement and some useful resources. And don't forget that you've got colleagues in the NHS. So myself and Kerry are leading quality improvement in care homes this year, specifically focused around managing deterioration and Restore 2. But there are other resources out there. You have care home nursing leads, matrons, you have care coordinators within your PCNs, you have colleagues in local authorities. There are quality teams in a lot of local organisations. So if you are looking for support, there's usually somebody out there that can help you. Next slide, I think that might be coming to the end of mine. Oh yeah, so we put this slide up just because it kind of sums up some of the frustrations people have. So the people pulling the cart with square wheels think they're too busy to fit the round wheels. And we find this quite a lot, that people see the work involved in improvement, but not necessarily the saving in work that will result after that improvement. Okay, next slide, Karen. I think that's the end for me. Thank you.
Thank you, Sean. I think that's really helpful to think about quality improvement, especially in the context of managing physical deterioration in our residents. When I speak to care homes, you know, they're very keen to start using this tool, but not really sure how to get started and how to roll that out across their services. And I think these small steps that Sean's been talking about, just thinking, what are you trying to do? Why are you trying to do it? Who do you need to involve? Are really the basics of quality improvement, and take away some of the jargon that we get in some of these QI learning sessions or methodologies. There's a big word straight away. So I think, you know, thinking it in small ways is really helpful. Just been really reflecting on the session today, and think how both speakers were coming from very different backgrounds and different spaces, but really giving us a time to reflect on a lot of our work is really understanding the people we're supporting, our residents, and what's important to them, whether it's that gender conversation, whether it is understanding what their soft signs might be or their baseline vital signs might be, and then how we use that across the system, how we communicate that to each other in an effective way, so that we're always thinking about what the best outcome we're trying to reach for the person that we're providing care and support for. So yeah, happy to hear any other questions or reflections from today. So I'll just give us a little minute in case there's anybody that wants to add to those thoughts. No? Okay, well, it's sort of something to take away and think about, and how from both those different aspects we can really start to think about how we support our residents across the system. We mentioned earlier in the session about the ESTA model, and that we were going to share information around that. So if we can put up the next slides, I think we've got 2 things we'd like to share. So the first one is about a project. We did actually mention it in a previous session that we've run about care homes. I'm sorry, that's so small I can't actually see it. I do apologise. I'm just going to move it over to my bigger screen unless everybody else can see it. Can we make it bigger at all?
Don't think so, Kerry. I think
okay. Well, it's about a study taking place still up until the summer, and they're still looking for people to recruit to take part in the study about monitoring safety in care homes. So something that might be something you could work with, and then look at a quality improvement programme for yourself around it. The second programme is the that's okay, next slide. The second one is the ESTA improvement coaching that we talked about earlier, and I think Josie mentioned as well that it's been quite a focus for Kent for a number of years. I've worked sort of in the local care forum, and we were looking at ESTA as far back as sort of 2019, and how can we really wrap a model around the residents throughout their care and support journey. So there's lots of levels of how you can interact with the ESTA model, and whether you want to be a champion, an ambassador, or a lead around it. And Kent are currently rolling out some courses. I think some of them are face-to-face, but we're also looking at online options as well. So we've put this link in here, so please sign up for that if you can. And if nobody's got anything else to add, then I think we're going to give you sort of 10 minutes back to go and grab a cup of coffee before you jump into your next meeting. So I'll just give it a couple of seconds in case anybody did want to raise anything. Sean? Oh, sorry. Okay, thank you very much, and hope you all enjoyed the session, and look forward to seeing you at our next one, where we're going to be doing some more QI, unashamedly. Take care, everyone.